Thank you, Madam Chairperson, for the kind introduction. Assalamualaikum and very good morning. So today our first lecture will be pre-op assessment in cataract surgery. This is a basic thing before you proceed with any cataract surgery. Okay, for today actually we will cover a few topics under pre-op assessment in cataract surgery, including the indication for cataract surgery, the ocular history, systemic history, ocular examination, pre-op investigation, and also informed consent. There are several indications for cataract surgery. Loss of stereopsis is one of the indications for cataract surgery. Others like decrease of peripheral vision, burdensome glare, and also anisometropia, especially in eye myopia. For example, one eye done already cataract operation and then patient developed anisometropia because of the different power. Okay? In ocular history, we need to ask patient about the pre-existing visual acuity, especially during childhood, if we suspect this patient has history of myopia. For example, a patient had already reduced vision since childhood with or without glasses. Okay, so it might suggest myopia. This is very important before you proceed with any cataract surgery because in terms of very guided visual prognosis, and then we need to explain to patient the vision might not improve much after cataract surgery. And then we need to ask any history of wearing glasses, especially in high myopia. This is also very important because we need to explain to patient the risk of anisometropia. For example, if one eye already went for cataract operation and then post-op operation will be different, okay, compared to the pre-op operation. So this patient might need a second eye surgery. And then any history of pre-existing ocular comorbidity such as uveitis, glaucoma, and other optic neuropathy. Okay, for example, optic atrophy, secondary to traumatic optic neuropathy, or a lot actually. And then history of ocular surgery also is very important because, for example, patient has history of trauma before this, underwent some ocular surgery, for example, corneal NS. So the operation for cataract operation is different a bit compared to straightforward cataract surgery. And then same as history of ocular trauma. This is also very important because let's say a patient has history of ocular trauma and then this patient sustained traumatic optic neuropathy, so the vision also might not improve much after cataract surgery. We need to explain in details, okay, before operation. For systemic history, most of our patients actually more than 50 years old, right? Okay. Overall, actually elderly with a lot of medical illness, for example, diabetes, hypertension, ischemic heart disease, and PH also, COE. So we need to make sure everything optimized first before plan for surgery. For example, if patient having ischemic heart disease, we need to ask in detail about the heart status, and then we should have the cardiology input also, whether this patient fit or not, although just plan for all under LA. Any recent skin or nail infection such as fungal infection, this is common, very common. So during pre-op assessment, we need to check from head to toe, okay? For the in charge pre-op assessment, we need to look very hard for this thing. If we just ask patient and then we didn't check properly, we might miss these findings. And then we just notice it during intra-op, just before operation on table actually. Okay, current this page also we need to ask patient about the current list of medication. For example, anticoagulants. Can you hear me or not? Okay. So we need to ask patient about the anticoagulants. Okay, any history of patient on systemic alpha inhibitors such as tamsulosin that might cause floppy iris syndrome. Can you hear me? Okay. So diuretics, so it can cause electrolyte imbalance, and also steroids, prolonged steroid. It might delay the wound healing, especially if patient underwent ECCE. So the wound much larger lah compared to Phaco wound. And then in history also, we need to ask patient medication that relate to the eye, and then such as sulfur-based drugs, because this is very important. For example, you want to give medication Preop, for example, Dimox, acetazolamide, so we cannot give to this type of patient, right? And also any antibiotics. If let's say patient allergic to certain antibiotics, we must alert. So we cannot give intra-op, for example, intracameral Zenacep is commonly given, right? Intracameral, intra-op, and also post-op for topical antibiotics. And then in history of reaction to anesthesia previously. Okay. Okay, in details, okay, for patient who have diabetic and hypertension, we need to ask whether control or not. And then for diabetic HbA1c, okay, we need to optimize. And then the random blood sugar not more than 10 millimeter per 10 millimole per liter. If let's say this not optimized set, we need to have refer to physician or dietitian to optimize the thing before plan for surgery. Same goes to hypertension. If let's say the systolic blood pressure more than 170 to 180, and or diastolic blood pressure more than 100, so we need to have input from physician also, because in this type of patient, there's a high risk of suprachoroidal hemorrhage. Plus the if patient obesity, short neck, everything. So this is much higher, the risk of suprachoroidal hemorrhage. And then for myocardial infarction, we need to ask patient when was the last attack. And then if let's say it's less than 6 months, so we need to defer the surgery, at least 6 months from the last attack. And then we need to have cardio input also, whether this patient fit or not, and then the cardiac status. And then we need to ask patient whether this patient on anticoagulant or not. But usually most of the surgeon, actually we didn't hold the anticoagulant medication unless we plan for ECCE or ICCE. So this one larger wound lah. So usually for straightforward Phaco, we don't refer normally. It depends on the surgeon also actually, surgeon preference. Okay. Okay, for COPD or asthma, also we need to ask patient when was the last attack, and then the current status whether fit or not for surgery. If patient cannot lie flat, so we need to plan operation to be done under GA, and then we need to have NS input also, proper pre-op assessment by NS also. If fit for op under local, so patient need to bring the inhaler or MDI to OT on the day of surgery. Okay, for patient with diabetic foot ulcer, we need to know whether this patient having acute or chronic, because sometimes we don't know whether this patient acute or chronic diabetic foot ulcer, right? Because patient will, oh, actually it's already there for 6 months or more than 1 year, okay? But we need to co-manage with ortho team. If let's say acute infection, we need to refer for the surgery, and then we need to have some systemic antibiotics or proper debridement by ortho team. If chronic leg ulcer, which is more common in diabetic patient, so might need to be covered with sterile dressing during peri-op and also prophylaxis antibiotics. Okay, for patient with stroke, we need to know also the last attack, when was the last attack, and then need to defer surgery also, at least 6 months from last attack. And any particular residual difficulties, if patient had stroke more than 6 months ago, or any anticoagulant medications. For patient with cervical spondylosis or rheumatoid arthritis, we need to check for the head and neck positioning for op. If let's say this patient had difficulty in positioning of the head or neck to be done under LA, so we need to do operation under general anesthesia. And patient with epilepsy also we need to know when was the last attack, is stable or not. If let's say it's not well controlled, and then after seen by NS, then we can proceed operation under GA if patient stable. Because we might worry that this patient might develop epilepsy during operation if done under local anesthesia. Same goes to Parkinson's disease or substantial tremor. Whether the patient able to control or not the involuntary movement. So if cannot, then we need to do operation under GA. And for patient with HIV, Hep B or Hep C positive, we need to rule out any current acute infection. For example, patient had pneumonia, okay? So we need to settle the acute infection first. And special precaution, if patient is stable, no acute infection, so we need to do as last case. It's considered as biohazard, okay? Special precaution for the surgeon and also the paramedic. Okay, in ocular examination, we need to ask, we need to check for the visual acuity that we explained before. Okay, visual acuity and then the refraction is very important to guide the intraocular lens implant selection. Okay, and also any squint. For example, this patient had history of 6 nerve palsy a few years back. Okay, so patient had some alternating exotropia. So most of the patient can control it. Okay, one eye can, close one eye can fixate. But if cannot, then we need to do under GA. Okay. In ocular examination also, the ocular admissa, we need to look carefully on the lids, look for any signs of blepharitis or meibomianitis. This is the meibomianitis, okay, due to the clog of meibomian gland, meibomian orifices, and also blepharitis, and also any lid abnormality, for example, entropion for patient history of chemical injury before, and also leg of thalamus. For the conjunctiva, any congestion that might suggest early conjunctivitis or any symblepharon due to previous chemical injury. Okay, so if this patient has symblepharon, we need to settle this one first. For the cornea, most of the patient, because elderly patient, will have the prominent arcus senalis, but generally actually have no really difficulty for the straightforward cataract surgery. But sometimes it might have some difficulty, especially for the beginners lah, the young surgeon, okay? And then patient with very dry eye in keratoconjunctivitis sicca, we might need to treat the dry eye first with aggressive lubricants before we proceed with cataract surgery. Because this patient might have, for example, persistent apical defect later on. So might be very difficult to treat actually sometimes. And then can cause corneal ulcer, everything. And then cornea scar also, we need to judge whether this cornea scar really disturb the surgery or not. Okay, intra-op. If let's say it's just faint cornea and then faint cornea scar, and then you can still view the capsule, okay? The entry capsule of the lens, we still can proceed. But if let's say very dense, okay, we might need opinion from cornea team. And also underlying corneal dystrophy. And then if patient have endothelial capitis, chorotic precipitates due to previous uveitis, we need to make sure that the eye is quiescent for 3 months before we proceed with surgery. And then we need to know whether this patient during the uveitis attack was on topical or oral steroid. So if patient was on steroids, either topical or oral steroid, we need to prime this patient. 3 months quiescent already, but we need to prime with steroid 2 weeks prior to, okay? Otherwise, it can cause rebound post-ovulation. It's also very, very difficult to control sometimes. And then if patient have cornea guttata, we must look carefully at the cornea, okay? We must slit the light. And then we might need to proceed with specular microscopy to look for the endothelial cell counts, because there's a risk of cornea decompensation. So in specular microscopy, if let's say they count more than 2,400 cells per micrometer square, mm square, then it's considered normal. If let's say less than 1,000, so you consider high risk of corneal decomposition. Okay. And then also precaution for operation. Okay, in ocular examination, entry chamber also is very important. For example, in patient with intermittent cataracts, or in PAC, PACS, or PACG, okay, so will be shallow. So this is one of the difficulty during the surgery for the surgeon. And then we need to look for the AC cells, like I mentioned just now. If there's presence of AC cells on the day of surgery, we need to defer first and treat the uveitis accordingly. So the pupil also is very important. We need to look at the presence of RAPD. This is the first thing actually we need to do after we check the vision. So if let's say there's a presence of RAPD, we might need to explain to patient that very guarded visual prognosis. Okay, the vision will be the same after operation. We cannot guarantee how much the patient can see because of the RAPD positive. So the patient must understand properly, okay, the prognosis. And then we need to check whether the pupil is well dilated or not. This is very important, okay, because if not well dilated, possible due to pseudo-X. That's why we need to dilate properly first, then we can assess how much the degree of dilatation. And then whether patient on guard pilocarpine also, the pupil not dilated as well. And commonly in diabetic patient, not so well dilated. And any presence of posterior senicale or anterior senicale might be due to previous uveitis. And then for the type of cataracts, okay, the lens, polar cataract is very important. So you need to look carefully for the presence of polar cataract. And then we need to avoid hydrodissection, okay? And then intermittent cataract, mature cataract, such as Morganian cataract. And then same goes to xenoidal apparatus. Look for the phacorenesis, subdilated cataract, and then present or not the pseudo-X. Examine the dilated pupil. High IOP also related to the lens-induced high IOP, such as phacolytic, phacomorphic, or phacoanaphylactic glaucoma. If patient have pre-existing POAG, we need to, if advanced, we need to explain to patient the risk of wipeout syndrome. And then fundus also is very, very important. If we can see the fundus, we must look carefully any abnormality in the fundus. Okay, this also might guide the prognosis of the cataract surgery later on. If there's no fundus view, we need to do B-scan to look for presence of retinal detachment or vitreous hemorrhage. Okay, for certain patients actually not suitable to be done under local anesthesia, we need to proceed with operation under GA. Okay, for example, in uncooperative patient unable to lie flat, unable to lie still, uncontrolled epilepsy or unpredictable cough, uncontrolled involuntary movement, deafness, or in children. So the pre-op investigation, generally we take the blood pressure, rectal and also ECG for the local. Most of the patient we do under local, right? And then for GA, actually we need to take the full blood count, BIOS, chest X-ray, or ECG, depends on the NS preference. Okay, the last one will be the informed written consent. This is also very important. It's one of the in the checklist during pre-op assessment. Patient should give informed written consent pre-op. It is a process when a communication whereby a patient is enabled to make informed and voluntary decision about accepting or declining a treatment or procedure. Most complications can be dealt with effectively, but rarely there might be some serious problem. In informed written consent, rather than complication during surgery or after surgery, there's a few things that have been explained in the written consent. For example, the procedure of cataract, what is cataract? What is the procedure of cataract surgery? And then what is the complication that might occur, and also the extra procedure or extra surgery that patient might need to go due to the complication, and also the post-op care, okay? This is a few complications related to the divide into local anesthesia, general anesthesia. For example, local anesthesia injury to the eyeball. This one if we give peribulbar or retrobulbar anesthesia. And then allergic reaction to LA, system effect which could be life-threatening and of death. For the GA, actually will be explained by the NS team. And then this is complication related to surgery. PCRAN, vitreous loss, unstable capsular bed, drop lens, ocular tissue injury, hyphema, and suprachoroidal hemorrhage. And then after surgery, there's a lot actually, okay? Increased IOP, macular edema, RD, endophthalmitis, capsular bed opacification, IOL-related complications such as malposition and opacification, acute or chronic inflammation, corneal decomposition, unexpected refractive errors, and then visual disturbance such as glare or halos, worsening of pre-existing ocular condition, and sympathetic ophthalmia. This is very rare. If you realize this is all the complication related to the pre-op assessment, right? So this is very important that we need to highlight during pre-op assessment. We need to look carefully, okay? From for the eye, from anterior to posterior segment, and for the systemic from head to toe. Okay, with that I just thank you.